and get to that why, it will make more sense kind of how we approach this disease as compared to others, because addiction is unique in that the definition of addiction ultimately means that they have a substance that they can't control or a behavior that they can't control. And then that has a number of impacts that just having diabetes doesn't necessarily cover. So while this may be a chronic neurobiological disorder, it's different because if you're diabetic and you crush a box of Krispy Kremes, you can just take some extra insulin. It's a little different if you go out and use fentanyl and you don't know it's fentanyl and you overdose and die. So this is different in a high mortality way, but also in a way that it impacts the community around us. And so let's walk through that a little bit. So if we think about survival, and to simplify this, I'd say we need three things to survive, right? You need food, you need water, and you need dopamine. And I know that my sciencey friends will be like, you need oxygen to survive as well. I'm like, yeah, you need skin too. But at the same time, we're going to focus on just kind of the food, water, and dopamine. And dopamine fits in here because it is the chemical responsible for motivation. In fact, when I say dopamine, you should think motivation. If I say motivation, you should think dopamine, because one doesn't occur without the other. And it's important to know that the more motivation we have, the more dopamine that's being released. The less motivation we have, the lower the dopamine is in our brain. And so that reward system release of dopamine helps us to work hard and have positive reactions when we are successful. It also drives us into relationships and is one of the major chemicals responsible for connection and joy and love and all of those things that we need a little bit of in order to be able to survive. And it's so important that the body has built really particular boundaries around it so that it stays within a basic realm of dose, in a sense. And so if we think about your normal day, like you woke up today, you had to drag yourself to the coffee machine and you get your coffee and you get in your car and you go to work, then that's that normal level of dopamine. It's about 50 nanograms per deciliter in this part of the brain called the nucleus accumbens. And in that part of the brain, when we release that, that's the daily normal amount that we need to get up and go. The day that we don't, the day that you want to call in sick and you fake vomit on the phone, be like, I can't make it today. That's about 40 nanograms per deciliter. So a little lower, right? And then at the high end, the best day of your life, right? The day you win the lottery, you own an island and you have 2% body fat all at the exact same time. That's the range. We've even looked at things like your favorite food. And when we look at your favorite food, the dopamine release is about 94 nanograms per deciliter. And sex is about 92 nanograms per deciliter. So bummer on that one. But either way, this is where we're supposed to be. Now, we know people who live on both of those spectrums, right? We know the Eeyores of the world that live closer to 40 on a regular basis, who nothing's ever okay. I'm not going anywhere. I don't want to do anything extra. We know those people. And then we have the people on the other end that are also frustrating sometimes because they're like, today is freaking Monday. It's awesome. And everything's great. That's really the tough group to deal with as well. But we still sit within this kind of 40 to 100 nanograms per deciliter. This allows us to work hard, play a sport, and feel awesome when we win. This allows us to put in work, put in time, put in energy, and feel great when we get a promotion or get a raise. Or, when I watch my kid play soccer and score a goal, or play baseball and throw somebody out at second. Those are all ways that I can get dopamine at this point. And if we leave the system in that setting, it does pretty good. We actually can be happy. We can have crappy days and we can have great days. And that's how it's supposed to be. That is just being human. The problem is when we disrupt that part of the brain that is responsible for maintaining a steady state, a little up and a little down. And if we add something to that system like methamphetamine, instead of that 100 nanograms per deciliter, we release dopamine up to about 1,100 nanograms per deciliter. And this isn't great because this shoots that body way past where it's supposed to go. And, we look at heroin, which is in the 900s, marijuana, which is in the 600s, and when all of those things really compare to the best day ever, the best day doesn't seem so cool anymore. This outsizes that. Now, the brain knows this isn't great. So what the brain decides to do is take a look at, you know, what's going on with, this large release of dopamine. And when that occurs, then we end up having the brain turn that dopamine down instantly. So the first time that somebody uses, methamphetamine, their brain will release this massive amount of dopamine, but it will never release that again, ever. The brain says, "Oh, that's not good. Not going to do it." This is why some patients will say, "I can't. I'm just chasing that first high." My patients will say, "Chasing the dragon," in a sense. They'll never ever get it for that substance again because the body has already learned. The body has already learned that that is not okay, and so by doing that, it'll turn that down. And if they continue to use, it'll actually decrease the amount of dopamine the brain produces. And then if they continue to use, it'll decrease the size of the cell. It will actually atrophy the cell that produces dopamine. And for methamphetamine and opioids, we actually find that over time, if the person continues to use that substance, the brain will actually go through a process called apoptosis and kill that cell. And so that's the equivalent of having a stroke in the happy part of your brain. So if we get to a point where we can't produce dopamine, either temporarily or permanently, then we lose that capability of normal motivation. I don't want to be in trouble, so I'm going to go show up and do these things. I don't want to lose my job, so I'm going to motivate and show up for my job. I don't want to go to jail, so I'm going to show up for court on time. When the brain doesn't have the ability to produce dopamine, then ultimately they can't create the motivation in the same way that we would when we have stable dopamine in the brain. And so yelling at somebody to be motivated and do the right thing who's had this happen is a little bit like yelling at somebody to make more insulin. It just doesn't make any sense whatsoever. So what happens when we, ultimately lower that dopamine? When we lower that dopamine to the point of not having motivation, the body starts to have some adaptations behaviorally that puts them in a situation where they feel like they need, to do something to get that dopamine. So they start to have craving. And this craving causes them to start thinking about, all right, what can I do to either get that feeling or get that substance that gets me that feeling? And when they can't get it, the brain spins up, not unlike being, starved or dehydrated, into survival mode. And that survival mode automatically turns off the higher level thinking centers. In fact, we have good functional MRI data to show that the part of the brain responsible for making these higher level decisions basically turns off. The frontal lobe is about 80% turned down in those situations, and we are functioning on just the primal action. I need something, I'm going to get something. I need something, and I'm going to get something. And so this can be something as simple as I stole $10 from grandma's purse. This can start with maybe I'm going to use mom's credit card, to I'm going to shoplift a t-shirt, and then I'm going to sell that for drugs, all the way up to I'm going to sell myself for drugs because I've run out of money, and if I don't get them, I'm going to die. And that is that survival mode feeling for that. And so when I first started in this specialty, I had a hard time with this one because I was like, yeah, but they can still make a decision, right? Like you can still sit down and have this. Well, as I started to really dig into the neuroscience of this and try to understand it at a deeper level, I realized that the decision matrix in this population is just not the same as the decision matrix for me. So I can't, if I have a decision to make, you do the pros and cons list and you're like, what do I do? Which one works? We'll do that. All of that is basically turned off because of this craving. And to show you to kind of describe how profound it is, there were some experiments done that looked at patients who were dehydrated for 3 days. So no water at all for 3 days, nothing in the IV, nothing orally. And then they put them in a functional MRI, which looks at the brain and how it functions at the time. And then they showed them pictures of waterfalls. They played water sounds. They sprinkled some water on their legs. And then they looked at the amount of craving that their brain had. And so that amount of craving that they had was about the relative size, not the actual size, but the relative size of a baseball. Now, they did the same thing for starvation. And when they did this same thing for starvation, then these people didn't have anything to eat for 5 to 7 days. They only got IV fluids so that we didn't have the dehydration stacked on top of it. And then they would show them pictures of their favorite food while they're functional MRIing them. They would bring in their favorite food and actually like waft the smell into the MRI tube so they could smell it, and then have them taste it and spit it out, like real kind of torture stuff. And what they found is that it wasn't the relative size of a baseball, it was the relative size of a basketball. And I think we all know what people will do in times of significant dehydration or starvation. I mean, we see them in countries right now. I mean, we see this on the news every day when they can't get food. That primal action that happens to get to that bag of flour, that bag of rice, those things. I mean, people will have significant primal actions that outside of those settings we could never ever think about. And so, like if I walked across the desert for 3 days and I didn't have anything to drink, and I get to the other side of the desert and there's this beautiful glass of water in front of me, and it's got the condensation. It's like the 7-Up commercial, and and you look at that and you go to grab it, and somebody steps in front of me and they're like, "That's my glass of water. You can't have it." I'd be like, "Okay," throat punch, move them out of the way, and I would take that glass of water. And that seems really logical in that moment because I'm gonna die. I need that water. And that amount of craving and disengagement from typical thought process comes from that relative size of a baseball. And for starvation, people will steal and kill other people for food and do all of these things because it has the relative size of a basketball for craving in the brain. Well, when we look at people who have had a heroin use disorder and alcohol use disorder, and we've had them off of those substances for 30 days, 60 days, 90 days. In fact, we found that craving went up over the first year. It didn't go down quickly. It actually took a year for craving to even stabilize, and that it took about 18 months to see any signal change in anybody for this. And that signal intensity for craving of that drug, when we would show them just pictures of it and ask them a question of describe the first time that you used and describe the last time that you used, it wasn't the relative size of a baseball or a basketball. It was the relative size of a baseball field. It was 10 times higher. And that frontal lobe that we use to make complex decisions was now pushed down to the 1 to 2% mark, meaning decisions were based on survival. They weren't based on logic or risk of punishment or if-then statements. None of that. It was, if I don't use, I will die. And that was what their brain was thinking. And interestingly, there are only a few ways that we can cull that craving in opioid, in addiction in general. But opioid use disorder is actually the easiest one to stabilize craving so that we can get them to start to have some logical thought. And that's where we start to use things like medication to stabilize dopamine. And we'll talk about that in a sec. But what does this ultimately mean? I think the fundamental piece to take away from this is that once somebody really meets the criteria for a substance use disorder, their ability to make a decision just is not our normal decision pathway. There is no pros and cons sheet on the refrigerator. It is out of survival mode. And so everything is there. And if you're trying to give them talk therapy in this moment, or send them to IOP, all they're hearing is rah, 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 rah. They're not getting anything. And for those of you on the phone who've treated these patients and you see them and you're like, we're going to learn some skills and we're going to do anger management, and we're going to do seeking safety, and we're going to do relapse prevention. And then they show up 3 sessions later and they can't remember one thing that you said. And you're like, you didn't learn any of this. The answer is no, because actually in low dopamine states, memory doesn't function properly. And so you need dopamine in order to onboard new memories. And the whole thought process behind behavioral therapy is to onboard new behaviors, which requires the memory of that learning to turn into a behavior. So when we just take somebody, pull them off of the drug that they've used, and we shove them into treatment, that's not helpful, especially in opioid use disorder, because the craving is so profound in opioid use disorder. And so medications for alcohol use disorder, and opioid use disorder and tobacco use disorder, and also marijuana use disorder in adolescents, they're just standard. Like, there's no question about this anymore. There's no philosophical argument in this right now. We've done this since 1972 with medications. We have thousands of publications. Not one of them shows a decrease in outcomes. Every single one of those thousands of publications shows an improvement in risk of death and an improvement of retention in treatment and a stabilization of their thought process so that they can engage in treatment. So there's not like a debate about this from the scientific standpoint. It just is in that standpoint. Just like I know that if you come into my emergency department and you have VTAC, I can shock you. And I can get some people about 20% out of VTAC. Yet, and because of that, we put defibrillators in every like Burger King bathroom just in case somebody happens to be in VTAC to put it there. With buprenorphine, I have about a 40 to 60% chance of decreasing their risk of death. So I have double to triple the chance of saving their life with buprenorphine or methadone than I do with a defibrillator. Yet people freak out about giving somebody a medication that saves a life. It baffles me even to this day. And so as we start to look at like why we need to, add these medications, it is purely to decrease the siren of craving in their brain so that we can actually start to make some progress with them. Now, I will say that while buprenorphine and methadone have absolutely shown to significantly decrease their risk of death, which obviously is the starting point for therapy, because I cannot therapize the dead person, and I'm quite sure Medicaid doesn't pay for a seance. So at the end of the day, I need an alive human being to be able to get them better. And if we decrease significantly their risk of death with these medications, then it makes it really, from a medical standpoint, completely unethical not to offer them. And I think this is agreed upon. I know that this is agreed upon throughout the totality of healthcare internationally, not in the US. World Health Organization, here, European, Australian, every organization, this is a standard of care. And so as we look at the pathways that we go, we also have to remember that it's not an instant change. Like it took years for that brain to change for most of our patients. And to think that sometimes in 30 days, 60 days, or 90 days, that magically you're not going to have a chronic neurobiological disorder, that's not okay. A lot of adjectives I could throw in there, but I'll just leave it at that. So it takes time for that to heal. 18 months for it to even start to change a little bit. And the data shows clearly that it's 3 to 5 years before we can start to wind down the risk. And that's only for about 40% of patients. The other 60% are most likely going to need to stay on these medications for an extended period of time. And the interesting part of this is that any study that we've done, large-scale studies in other countries, in our country, show that even after 5 years, if we wean somebody off of the medications, greater than 90% of those people weaned off, even with social work help and therapy and all those things, will relapse within that first year afterwards. And for opioids and fentanyl, that could be a death sentence. And so this is super high risk. So this is the thing we have to weigh back and forth about. Is this forever or is it not forever? And can we do it? I will tell you that while medication not fixes, but at least stabilizes the craving, it significantly improves the behaviors of the patient so that they can go into remission. It's not the only thing that they need. Like medication is not the whole thing. It's a piece, and it's definitely where we should start. But we need behavioral therapeutics and long-term case management to be able to unwind all of the problems that have either preceded the use of that drug, the trauma, the depression, the anxiety that led to that first use, and then all of the subsequent aspects that have occurred afterwards. So if we want to improve their function, that requires behavioral therapy and all of the other pieces of this. So when we start to look at how we build a system for those in the justice-involved system, whether it's in a carceral environment, probation or parole, or a diversion program, the fundamental piece is that they need medication first and fast. Then we start to unwind all of the functional pieces. And at some point, a portion of them will be able to wean off of those medications and be stable, but there are a subset of the population that just won't, because the neurobiology is just not going to allow it. And so if we look at the outcome studies in California. So over 2 years, I spent time in the California prison system. I could leave anytime I wanted, but just to be clear, implementing medication-assisted treatment, or MOUD, inside of the walls of the California prison system. When I started there, it was about 153,000 people, and then COVID hit, and then a bunch were released, and so we had about 102,000 at one point. Still a massive number of human beings, and I will tell you that every prison has its own culture, its own reality in California. So despite a consistent approach, it was very different depending on where you went. So when we started, we had about 30 plus patients on medications, and I'd say about 20 of them were on naltrexone, so long-acting injectable naltrexone or Vivitrol, and then we had like 10 on buprenorphine. And we went from there to 17,000 patients on a combination of buprenorphine and naltrexone. The clear majority of those, like 85–90% of those, being on buprenorphine. And what we found from that were that overdose deaths in custody decreased by 58%. That is a huge number. That was year on year, and that has actually continued to slowly improve over time. Hospitalizations for overdoses and soft tissue infections decreased by 18 and 21%. So people were injecting less, and then the dangerous pathways that were happening with the drugs decreased. We also saw a significant lowering of the reinfection rate of hepatitis C, and then a 61% decrease in overdose deaths after reentry, and that was 1 year after reentry. So that is a massive impact on a population that is super high risk. And then the cool part was that about 85% of them actually stayed on MAT after release at that 1 year mark when they were evaluated for those pieces. So this is doable. It is doable at scale. So it's not just, well, Rhode Island did it and they're one place, and everybody's like, well, we're not Rhode Island. The answer is no, you're not Rhode Island, you're not California, but I guarantee you can find something that looks a lot like what you do in between those two, for sure. So if we look at some of these myths that I run into all the time, one of them would be like, aren't you just trading one drug for another? And the answer is no. Addiction is not defined by the presence or absence of a drug, but rather the behaviors associated with obtaining or using the drug. So if we define it based on the behaviors, and I give them buprenorphine and they take it as prescribed, or I give them methadone and they take it as dispensed, then, and the behaviors associated with obtaining or using the drugs go away, then they're in what we call remission, which means they don't have an active substance use disorder anymore. Now, people will start to get confused when we talk about physical dependence on a substance. So physical dependence on a substance is that if you take a substance, almost any substance, over an extended period of time, your body can develop some tolerance to that medication. But if taken as prescribed, that doesn't factor into the definition of a substance use disorder. And I think the biggest piece here is that if we're successful with these treatments, we do stop those compulsive behaviors, which means they're able to now create a pros and cons sheet for their decisions. They're able to make logical, appropriate decisions based on input from other people, based on behavior changes that increase their output. And over time, we stabilize that dopamine axis. And that, once we hit that 18 months to 2 years, if everything's going great and they want to try to lower dose, fine. But if they don't, fine. Like, we get weird about this. If somebody starts on a blood pressure med and they want to exercise and lose 30 pounds and get better and not need it, great. But if they don't, we don't stop their blood pressure med. So at the end, we need to keep them alive and keep them functional. The biggest risk to losing their life and losing that functionality is stopping the medication abruptly. And so this is really important to keep in mind as we build out a system of care. And these are what we use for the these are what we use for the diagnostic criteria. And if we look here, we have issues with impaired control, social impairment, and risky use. And then on the bottom, the pharmacological properties are if they're using illicit substances, i.e. buying from the street, heroin and that, then tolerance and withdrawal helps us to understand the severity of the disease differently. But if prescribed, those are not included in the diagnosis. Now, one of the other ones that I hear is we need a full continuum of care. If I started here, I don't know what's going to happen. Again, we go back to those numbers. 40 times more likely to die, 74 times more likely to die in the first 2 weeks. And then, the year afterwards, 10 to 18% higher after this. You don't need it. You don't need the full continuum. You just need to be able to get them somewhere where they can get medications and then identify how you get them set up with the functional therapies, that significantly improve them long term. And I just want to also put down, what are the things that are shown here? So if you look at improved patient survival, that's just medications. Behavioral therapy doesn't improve risk of death. Either does naltrexone, interestingly. Only buprenorphine and methadone have been shown in studies to decrease the risk of death. Happy to answer questions about that, but that's been shown over and over again. It's not one study. It increases retention in treatment. Methadone is the thing methadone and buprenorphine have been shown to increase retention in treatment. Decrease illicit opioid use at the appropriate doses, MOUD only. It's only above 16 milligrams on buprenorphine and above 90 milligrams in methadone that show that. Ability to gain employment, that's a combination of MOUD and behavioral health. Improved birth outcomes for females, that's MOUD only and MOUD with behavioral health for that. But, so we can answer to any of these pieces, but they're ultimately the medications do most of the upfront heavy lifting for this. And with the medication-assisted treatment, again, we decrease their risk of death by about 61%. And just to reiterate, most continue it. Most willfully and wrongfully continue that medication afterwards. The other thing, people talk about risk. I'm not a lawyer, so I'm not going to spend a ton of time on this, but I just think that it's important to understand that there have been a lot of cases in a lot of different locations that have looked at a couple of things. So one is the Eighth Amendment. Eighth Amendment violations of cruel and unusual punishment. It has been found over and over and over again that to withhold medication is an Eighth Amendment violation. And I'll leave it at that. It also is an ADA violation. So Americans with Disabilities Act. This is also both encased in case law as well as the DOJ. So to withhold life-saving medication is a violation of the ADA and is a violation of the Eighth Amendment in case law. There has not been one case that's gone the other way in this. All right, so what is the system that we need to understand a little bit? So first, I'll walk through kind of the components of care. So take a breath for a second. That's a lot of information. and if I sum it all up, addiction is a chronic neurobiological disorder with very predictable behaviors. Those behaviors, for the clear majority of patients, are stabilized with medications. If we use methadone and buprenorphine, we significantly decrease their risk of death and improve their retention in treatment, which allows us to add behavioral health so that we can improve their function, i.e., getting a job, being a better family member, finishing their probation in an appropriate way, all of those things. But one thing that I do find is that there is a lot of confusion around the treatment system and where people should go. I find that people just always send somebody to, quote, detox or residential treatment or IOP. That's not how this works. We actually define what level of care somebody needs based on what specific input they need. So there are 4 components of care. We have medical care. That's the medications I talked about, withdrawal management, infectious disease, and pain management. Those components are for the medical care. We have psychoeducation, which are typically structured didactics, more group focused. Those are things like anger management, seeking safety, relapse prevention, men and women seeking recovery. Those are things that have significant data behind them and can be delivered by a counselor, like a CADC. And then we have psychotherapy, which is typically delivered by a master's level or higher person. That's CBT, DBT, EMDR. And those typically require a secondary certification or secondary training. And then we have the addiction treatment supports. And those are things like teaching people to work back, to be back in the community, to function properly inside of an environment of a co-living situation. So just learning how to re-enter the world, in a sense, like just to be around other people and not rapidly spin up or assume horrible intent from everybody around you. Those things that unfortunately are protective inside of a carceral environment, become pathological outside of it. And so the addiction treatment supports become really important, mostly delivered by peers and in settings that are not delivering psychotherapy or psychoeducation, but just reentry housing, recovery residencies, and then even out in the community. Now, everybody needs all of this at some point, and but everybody needs a little different version of it. So we have those that need medical mostly. We have those that need mostly psychoeducation, those that need mostly psychotherapy, and those that need mostly addiction treatment supports. And so to figure that out, we have to run them through kind of the cycle. And so we start with, you come in, we determine what level of care you need to go to, and I'll show that in a sec, which means we do that with the dimensional admission criteria. We look at the dimensions. We have 6 dimensions, and that is, withdrawal, intoxication, and medication starts. That's medical problems, psychiatric problems, and those are the first 3 dimensions. Dimension 4 is looking for a continued, abnormal behavior secondary to seeking or using the drugs, and then 5 is going to be recovery environment interactions, which means, do they know how to function even in a safe place to live, or do they have a safe place to live? And then 6 are patient-centered considerations, which means this is the thing that this is the reality. Like, am I going to go? Can I go? Does that level of care exist in where I live? And that stuff. We then they get put at the right level of care. And then we do a deeper treatment planning and assessment done by a combination of a medical provider, a behavioral therapist, and a case manager. And then reassessment, treatment plan, and review. And then this just keeps going until we get the patient stable. Now, these are the levels of care that are dedicated to the treatment of addiction, which is why I find it infuriating when I have a judge adjudicate a specific level of care. I call that practicing medicine without a license. And ultimately, they should just adjudicate. You need to get an actual assessment and follow the care plan that's developed from that assessment. That should be what is stated. That should be what's held to probation and parole and all of those things. But if you look on the right, 4 and 0.7s, those are the people who need medical care. So those are the people who have an issue with dimension 1, 2, and 3. 0.5s are where psychotherapy happens, and that's somebody who needs psychotherapy, so more dimension 3 and 4. And then 0.1 is somebody who needs more psychoeducation. And then we have those that are in long-term remission, or those that need recovery residency, which is purely dimension 5. And we have to determine which of these places they go. And that requires a knowledgeable assessment done by an actual behavioral therapist and a medical provider to be able to get this done correctly. All right. So I just want to throw this in. There's always a question about this. So laboratory findings, I'm going to start with a couple of things. You have 2 different kinds. You have an immunoassay, which gives you a positive, negative. And then you have a definitive test, which tells you about specific substances. If you are not trained as a medical provider, I would ask that you do not ever try to interpret these tests, because a negative immunoassay means nothing to me. It just means that there wasn't something that bound to that antibody at the right level. A positive definitive tells me what substances are in the system, but only if we looked for them. So we have about 70 that we can look for, but there's about 130 out there. So these 2 things combined can be very helpful to those of us who know how to interpret that. But a positive on initial screening, like for amphetamines, has a number of things that could be false positive. Also, if I have a positive marijuana, but a negative definitive for marijuana, that could be that they're using something like K2 or spice, because it's not going to show up on my definitive. And then we get numbers here, like the result will give us a number. And I will say only about 25% of board certified addiction docs know enough to effectively use those numbers. So if anybody on this call is using those numbers to determine if somebody's taking their med or not, please stop that. That is inappropriate. That's just wrong. And in fact, it just opens up a pathway for appeal if you're in the legal realm, because you're going to be wrong 99% of the time. There's not a result with very few exceptions, that I couldn't sit on a stand and debunk because of all of the realities that have to take place to get a certain level. So please don't use levels. And also, it harkens back to this basic thing where it's not about the presence or absence of a drug. It's about the behaviors associated with obtaining or using the drug. So a positive result does not mean that they've relapsed back into addiction. It means that there is a substance in their system. And recognizing that that's not a desired outcome, it doesn't mean that they had much choice in that. I mean, I've spent a lot of time in the communities. I did street medicine in Canton, New Jersey, and I will tell you that there are situations and places that if you don't use at that moment, then you're seen as a narc and you're going to get shivved in the frickin' street. And so there are just realities to this situation. So from a reentry and law enforcement standpoint, I think we have to be really mindful of the fact that it is problematic to assume that a decision was made to use. This should be looked at as you might need a higher level of care, you might need this, you might need that, we might need a change in therapy, but to use it as a means to put somebody back in jail, in my mind, is the most inappropriate thing that you can do. And I could talk about this for a very long time, but I want to leave some time for Emily here to walk through these next few slides, and I will start to answer these questions in the chat and Q&A while she does that. So Emily, go ahead and let me know when you need me to start changing the slides.
Real quick, before Emily starts with the stages of change, just wanted to let everybody know that a link to today's slides and a certificate of attendance has been put into the chat. Speaking of the chat, we want to hear from you. What's your experience been with Matt? We'd love to hear that. What's been your experience serving people in addiction treatment? We'd love to hear about your experiences with that, your take on that as we get into the stages of change with Emily.
Alrighty, so today I'm going to be going over a overview on research around change behavior and how you guys can be working with your justice system involved population to increase motivation for those changes we're wanting to see with the people we work with. So we're going to be going over what's called the trans-theoretical model. I'm going to refer to it as the stages of change because that's much easier to say. This was developed by two psychologists back in the 70s. So this has been around for a long time. This isn't necessarily groundbreaking research I'm sharing with everybody, but I think it's very helpful and very important research. And there's very easy takeaways that everybody could be using in their day-to-day interactions with probationers, individuals you're serving within the justice system. So historically, before we had access to this research into how humans develop the capacity to change, it was typically accepted that motivation and change were more fixed personal characteristics. We now know that motivation in itself is very fluid and it's very interactive with external factors. So this means that you, within your role in the justice system, play a vital role in nurturing change behavior. So the stages of change model describes the internal process that's going on in our brains when anybody's working on creating any change. So we use this quite a bit in treatment and educating our patients on where they are in the stages of change, helping them identify that, but you can use this for any change you're trying to make in your life or anybody's trying to make in their life. This model consists of 5 stages, each characterized by unique behaviors. Before we dive into an overview of each stage of change, I just want to take a quick second to discuss a few things I'd like you to keep in mind. So I know we're all on this call today to discuss substance use, but I want to encourage you to consider changing your thought process to viewing substance use as a problem behavior. Circling back to what Dr. Waller was talking about earlier, addiction is not defined by the presence or absence of a drug or substance, rather by the behaviors associated with obtaining and using the drug. So really, really marinate on that while we're working through this. Another thing I'd like you to keep in mind is that change is not a linear process. Even though this model outlines these stages in very pretty, clear, concise stages, it's typical and it's even expected for individuals to progress through these stages in a nonlinear fashion. That doesn't necessarily mean that somebody is less successful in their change. I also want to take a second to touch on the value there is in actually going through these stages in real time. I know we would all be so much happier if everybody would just skip from pre-contemplation, go right into maintenance, and then we never have a problem again. The world would probably be, we would have much easier jobs, I'm sure. But there is a lot of value in actually going through these stages of change for setting up a sustained recovery. So keeping those things in mind, let's jump right into our overview of the stages of change. Pre-contemplation is the first stage. In this stage, people are typically unaware of their problem behaviors. No matter how obvious it is to you, to me, to everybody else in their life, they don't have the ability to recognize that at that moment in time, and they typically have no intention of making any changes. So pre-contemplation, after that comes contemplation. This is probably where you start to see a lot of people you start working with. At this stage, they start to see the impact of their problem behavior. They see the impact it's having on their life, probably getting into some legal trouble. A lot of people that we work with, the event that gets them started on their pathway of recovery is their legal issues. So like I mentioned earlier, you guys just have an immense impact and power with the communities we serve. The next stage is preparation, and this is where we typically start seeing our patients. I personally love the preparation stage. That is like my meat and potatoes in recovery. Back when I was working more patient-facing as a counselor with BrightView, this was my absolute favorite stage to work with. There's so much potential to nurture change. It just really collaboratively help individuals build out their pathway to a sustainable recovery. And the preparation stage is exactly what it sounds like. You're preparing, you're planning, you're working on a game plan, a treatment plan, or a probation plan to really figure out what does this person need to support their recovery, and how do we find the right components at the right time to support them. The next stage, action stage, again, it's exactly what it sounds like. In this stage, individuals are working on addressing their problem behaviors. They've typically been doing this for a minute now, so they might have had some slight setbacks, but they're able to articulate, they're able to understand their setbacks, and they're able to put those changes into action. And maintenance, once again, this is exactly what it sounds like. Somebody has made a change for a good while now, typically more than 6 months at a time with that sustained change. And like Dr. Waller mentioned earlier, that doesn't necessarily mean that there hasn't been some returns to the problem behavior or some periods of relapse, but their overall understanding has helped guide them into the maintenance stage. And those periods of return to use are less and less frequent. And the biggest thing that I like to see value in when I was working with patients was, could they understand what happened? Could they dissect their return to use? Could we really unpack it together? That, in my mind, showed a lot of indicators towards somebody moving strongly towards a sustained recovery. So maintenance stage, like I said, exactly what it sounds like. Somebody has made these changes and they're making bigger changes in their life to sustain that change behavior. I also wanted to highlight another step that's not necessarily in this graphic, but that is a real, it's an intricate part of the stages of change model, and that is the return to undesired behavior, or even sometimes it's called the relapse stage. So like I mentioned, this model, it looks very pretty in this graphic, but honestly, it could just be a circle with a bunch of squiggles all over the place, because people can jump from pre-contemplation to contemplation, back to pre-contemplation, go into action, maintenance. They could have a relapse or a return to use. I'm not saying a relapse or return to use is a part of everybody's journey in recovery, but it's a pretty common and can be even an expected occurrence for individuals with substance use disorders. One thing, like I mentioned earlier, that's very valuable indicator of moving towards a sustainable recovery is when somebody could really unpack the behaviors that led to that specific return to use. So unpacking, of course, people, places, and things, who they were around, everything that was going on in the moment. I know we're getting close to the end of our session. If we want to skip actually 2 slides ahead, I'll make a quick recommendation. There's a guide that I'll make sure we put in our email follow-up as well, just kind of going over if any probationers or parole officers on this call are interested in learning some more motivational interviewing techniques, we'll link the guide in our follow-up. It's free, it's online, really great information. But in the time we have left right now, before we get into Q&As, I just want to take a quick second to speak directly to our judges and specialty court staff on the call. First off, thank you. I just want to take a second to thank you for what you do. You have an incredibly difficult position. I've had the pleasure of observing dozens of courts that we serve, and it's just amazing to see the work that's being done with this population. I don't think you guys hear it enough, so thank you. Before then, I just want to also highlight a recommendation from a study that was done in 2012 outlining 10 best practices for drug courts to incorporate to improve their outcomes. I'm sure everybody's nowadays is looking for a cost-effective way to improve their outcomes. This study found that courts that made changes, no other changes aside from the length of time the judge spends with each participant, minimum of 3 minutes, saw a significant decrease in recidivism rates. That right there is what it's all about. It also found that by making no other changes other than doubling that to around 7 minutes, they saw almost double the reduction in the rates of recidivism right there. So highly recommend. I've linked that study in the citation below. If you guys got a quick minute, definitely check it out. There's some great information there. We can go on to the next and last slide for me. The biggest thing I want to drive home today is that your words, your time have an immense impact and an immense power to nurture change behavior in the people that we serve. The language we utilize, it might be a little long-winded. If you've been in a meeting with me before, I'm pretty long-winded when it comes to some of these things, but it's important. These are people that we're dealing with. These are humans. These are people that deserve dignity and respect, no matter what they've done to get where they are in front of you when you're meeting with them. The easiest thing to do is just to change some language you're utilizing. And I want to make clear that if you are a part of a recovery community or in long-term or any kind of recovery yourself, you can use your own language to refer to yourself. Some people find a lot of empowerment in some of these terms. So I'm not saying everybody should change their language, especially if you're a part of the recovery community. But as somebody removed from the recovery community from personal experience, there's a lot of power in changing your terminology from addict or user or junkie to person with a substance use disorder, person in long-term recovery, person who previously used drugs. Another big thing I hear a lot is clean or dirty. Just changing your language to testing negative. The results were consistent with expectations. These language changes might sound like I'm being a little picky, but it really does go a long way with building that rapport, that trust with that individual you're working with, and that in itself will improve outcomes. All right, so I think we can open the floor for a Q&A.
Yeah, I know we're at time, but I'm happy to stay around if there are questions we can answer.
All right. One of the big questions that we got asked a few different ways here today has been about tapering and how does someone do it? When should they do it? A lot of different questions about tapering off of the medication.
Sure. I think the basics are tapering is only risk. Like there's never a time that it does not increase the risk to the person. It doesn't mean that there's not a subset of people who can taper off and maintain their stability and be in that remission. The problem is we don't know who they are. Like we don't have a good tool.
Dr. Waller, it says your mic is on, but for some reason we can't seem to hear you.
All right. Well, that's a problem. Sec. Can you hear me now? Now. Can you hear me? How about now? Okay, you can still. All right, I guess it's you guys. Panelists don't need to hear this anyway. They've heard enough of me. I think at the end, one, people say, well, the people don't want to be on this medicine. And the answer is, says everyone on a medicine everywhere, every time. Like nobody wants to be on a chronic medication. Nobody. Our job as healthcare professionals is twofold. One, to talk about the risk and benefit of being on that medication, and then to really help them to understand what happens if they do relapse. There's a huge thing. I mean, a lot of these patients are in a really tenuous situation with their family, with their work, with all of these things. And one relapse can not just be a relapse. I mean, it can be you go back to jail, you lose your kids to CPI. I mean, there's so much risk that goes along with weaning patients off that if they don't have side effects and they're just waking up and taking a med and they're fine, it's all risk. Now, have I weaned patients off? Sure. Yeah. If I do wean somebody off of buprenorphine or methadone, we take our time, we make sure they see behavioral therapy, we make sure we do a lot of check-ins, and then I typically would transition them over to naltrexone injectable so that they're covered at least for a period of time. And then even then I would transfer them to oral naltrexone to have in case things go weird. Because the thing that I always tell my patients is that relapse, no matter where you are in your lifespan, the biggest risk for that relapse are the best times and the worst times. Best times, you just got a promotion, life is great, that's high risk. Worst times, you had a breakup, you had a death in the family. Those are really high risk times, and they're really difficult to predict. And so those are the times that if you're not covered with medication or you have some access to come back and get care, that can be really, really high risk.
All right, thank you for that. And how does BrightView handle diversion?
Yeah, so a bunch of ways. So one is when we see our patients, we'll see them at minimum weekly for the first 4 to 6 weeks. We do random pill counts, we do tox screens, so we'll do a combination of all of those pieces. And so if we find that someone has a toxicology screen that's not consistent with taking their medications, then we have them daily dose at our places with OTPs, or we don't extend out past a week. We are not a place that just gives you 30 days and good luck, period. We should be considered a comprehensive addiction treatment program. I think there are 2 versions of addiction treatment programs right now. There are those that are what they would say is pure harm reduction, because we're in a crisis and people are dying. That's not a wrong statement. And I think we're having difficulty getting on top of this disease. But at the same time, we also have to be building a high quality, high predictability system of care. That's what we do. That's what we're doing. That's why I'm the editor-in-chief of the ASAM Criteria, which is the criteria used to determine the levels of care nationally and internationally. And that's why we at BrightView feel that it is really important to not just give you a pill, but to give you the pill plus the life around it. That is the behavioral therapy, the case management, the touch bases with peers, the ability to pop in if you need to. We'll see you the same day. We'll walk in, we'll modify doses, we'll switch medications, we'll work with you on all of those. And oh, by the way, if you happen to have alcohol use disorder, we do that too. Methamphetamine use disorder, we do that too. It is not just a singular approach. And so I think that we do everything that we can to significantly decrease the risk of diversion. The data would show that as you increase access to medication-assisted treatment, that diversion actually goes down in a community. There's been research on this. Most people don't divert buprenorphine for anything other than trying to not use other substances, interestingly. It doesn't change what we do, but we are the most overseen type of business there is. We have DEA, SAMHSA, licensing, local sheriffs. Everybody wants to know where our meds are going, and we track them closely. So it is important to us, and we do make sure that we keep an eye on that from patient to patient. Great question.
Okay, one more question, and if anybody's got questions here in the chat that we haven't answered, we'll definitely follow up via email. But can you speak a little bit about dosing? Once a patient has started the program, how do we make sure that they don't have too little or too much?
Can you say that again? You cut out at the end.
Sure. No, we're just trying to figure out with dosing, like how do we determine with a patient what steps are taken to make sure that they're taking the right amount versus too little or not enough medication?
Yeah, no, that's a great question, and one that I work with regularly with all of my providers. We actually track our average dose per patient because the data is very clear that if our goal is to decrease the use of illicit substances, the only dose that's been shown to do that is 16 milligrams or greater of buprenorphine, or 90 milligrams or greater of methadone. And you actually get an improvement in outcomes as you go up that ladder. Now, these doses have changed over the years because before heroin without fentanyl, people had less tolerance and less issues. So while that may sound high, all of our patients, we typically try to start at 16. And then if they need more, we give more after a period of, if they don't have any side effects to 16, we try to keep that on for as long as we can, mainly because we know that that's the protective dose, so to speak. So somebody on 2 milligrams, non-therapeutic dose. Somebody on 4 milligrams, it's therapeutic for helping keep them involved with care, but it doesn't change their chances of using another illicit substance. 8 milligrams doesn't change that. 12 milligrams doesn't change that. Only 16 or above for a population. Now, again, every time that we say these numbers, it doesn't mean that there's a few people here or a few people there. It just means that in general, the data shows that above 16 is the safest dose to start with. So we typically start there, and then we either titrate up based on what their tolerance was, or over time titrate down, but rarely would you see us go below 8 because it becomes non-therapeutic at that point. It's like giving the wrong dose of an antibiotic and hoping it fixes the infection.
Okay, we have another person asking, how do we help the inmates being released on MAT to not withdraw before they get to a program like BrightView's? In this person's experience, they are, and that is happening. So, like, how can we work together to try to address that?
Is this the question about how do we help the inmates being released on MAT to not withdraw before they get to you?
Yes, correct.
Yeah. So we do same day intake. So don't release them on a Sunday. Like, don't release them at 3 o'clock in the morning on a Saturday, because that's the stuff that happens. If you try to coordinate that release to be able to say, you got your last dose Monday morning and you can follow up Monday afternoon. Here, have this be their first stop. I know they want to go everywhere else in the sun, but a lot of the overdoses that happen right after incarceration happen in the frickin' parking lot. I mean, it is super scary how quickly that happens. So whatever we can do to get them, together with a ride to the office so that we can get them handled. But we will see them same day or next day, almost all the time. I rarely is there ever a time that it takes more than 24 hours for us to get a patient in. And so I would recommend just making sure that when you set a release date, don't do it on the weekends or in the middle of the night, and make sure that they've gotten a dose when they leave. In a perfect world, your providers would actually write them for a few days of medication, which they can do. There's no law or reg against that. I find that there's a lot of hesitance for that, the same one in the emergency department, but that's the best way, is if you just write them for a bridge dose and make sure they get to us.
Just to jump in a little bit and build off that, Brandy, we like to work really closely with our reentry councils, with the prisons and jails and the communities we serve. I saw you mentioned you're around the Chillicothe area. I'm going to reach out to you via email. Maybe we can partner on tightening the gap there. Ideally, we would be receiving some information. I know it sounds like a release date is something that's kind of fixed in time. We might not be able to control that on either end. It just kind of, they get released when they get released.
Yeah.
What we can do is we can maybe partner, and if you are having somebody that's working on like discharges or anything like that at the jail, we have community outreach managers at each of our locations that their whole job is to just work within the community and make sure that we're doing everything we can to just tighten that gap when it comes to reentry and linkage to care at BrightView. So Brandy, I'll be reaching out via email shortly after this call, and hopefully we can connect and work on something.
Okay, we appreciate everybody's patience. One last question. We have a attendee that just wants to clarify the discussion around dopamine release. She's in the understanding that creating and completing SMART goals for participants helps to release dopamine, which also, helps create new pathways for future success. Is that accurate in your, as far as you know, doctor?
Yeah, no, I think that that's a part of what therapy ultimately does is those SMART goals create a pathway toward quote reward, and that reward is completing that goal. And so contingency management is ultimately the most effective version of that inside of addiction treatment. But again, that's for patients who are in a place where they can naturally produce dopamine. There's a subset of our population who are super flat affected, who some of those things just aren't going to work, and we have to build more of a dialectical behavioral structure around them in order to get them stable over time. But yes, those are the natural ways in which we start to rebuild the neurons to get there. And you'll find a lot of those pathways in mindfulness-based cognitive therapies about allowing yourself to feel rewarded for basic things, and a lot of that. So yes, SMART goals is one of those ways. A lot of the seeking safety, a lot of the relapse prevention is around seeing yourself succeed in a positive way. So yeah, definitely one of the ways to get there.
Wonderful. Okay. Well, we appreciate everybody staying on. We've gone well over, but it's been a great discussion. I want to thank both Dr. Waller and Emily Hirsch for joining us, and all of you for staying on and asking your questions. We really appreciate it, and hope everyone has a great day. Thank you.
Thanks, everybody. Stay safe.